Diffusion-weighted image starts its life as a T2-weighted image. So it's essentially a T2-weighted image, and then you employ, just let me figure out this laser pointer, then you have diffusion-weighted gradients and a B factor, which makes that the signal is lost. So we lose signal from the T2-weighted image, and that is proportional to the speed of water movement in the tissue and proportional to the B factor. So if you have a tissue that diffuses relatively slowly, like swollen neurons in an acute stroke, the signal will be maintained compared to the normal brain tissue, and therefore it will appear brighter on the diffusion-weighted image. If you have something like CSF or cyst, then the diffusion, the water movement will be quicker, and you lose your signal faster, and in the end, it will appear darker on the diffusion-weighted image than the normal brain. And what really makes out your contrast between the on the diffusion-weighted image is dependent on the B factor and of the speed of water movement. Now, most clinical imaging is done at a B factor of 1000, but there are others, applications for higher B factors. You just lose signal and you need to do more repetitions. That's why it's not so popular. And it looks at different compartments of diffusion. So higher diffusion weighting, higher B factors look more at the membrane-bound water, and lower ones look more at the free water, and very low ones look basically at vascular perfusion. So here's an example. It's a frontal glioma. That's how it would look like on a T2-weighted image, which is B0. And then as you apply a gray gradient that increases, you lose signal, first in the CSF, but then also gradually in the tumor. You may be confused about diffusion tensor imaging, fractional anisotropy, mean diffusivity, apparent diffusion coefficients, and so forth. It's actually not that complicated. Once we establish we're looking at water movement, you look, I put this in because I like the German word eigenvector. So water can move in 3 different directions, and if it's anisotropic, then it looks more like an ellipse rather than a round ball. And what you look in normal clinical diffusion-weighted imaging is the mean diffusivity, which is the average of all of these vectors. And it doesn't give you any idea whether it moves preferentially in one direction or another. If you look at fractional anisotropy, it's a coefficient of the variant of these eigenvalues, and that's much more elevated or much more important in organized white matter tracts. And that is the basis of diffusion tensor imaging. You can also extract other things like axial and radial diffusivity, which would be just this direction or the sum of those 2 vectors. And this is currently more applied in research. And for example, in Alzheimer's disease, it is much more important to look at axial diffusivity than radial diffusivity. One detects, talks about myelin integrity, the other one of axon integrity, and so forth. So that's the theory. For the moment, the most of the talk will stay with the mean diffusivity and a little bit of fractional anisotropy. So if you have these fractional anisotropy maps, you can have color-coded maps, and these are just areas where there's a very organized preferential diffusion in one direction, like here in the corpus callosum, and you can have these anisotropy maps which are color-coded for direction. This is the corticospinal tract, so that's superior, inferior, and so forth. So that's the next 2 slides is where I really want you to pay attention, and that's the only take-home message. Afterwards you can go asleep because, well, you probably wake up in between. But the T2-weighted image, the contrast is the tissue T2. Then we have the ADC map. The ADC map is a map which is a quantitative map which tells you the degree of water movement. Not the direction, just whether there is a water movement, whether it's big or not. The diffusion-weighted image, which you always look at in clinical practice, has actually both effects. It's dependent on the T2 and on the water movement. And therefore, you can have artifacts like T2 shine-through and T2 masking. Let me show you what I mean. This is a case, it's a young Mexican lad who went to the gym, had some funny sensation in the neck and felt a bit funny, so he probably had a stroke about 2 weeks earlier or so. Then he decided to go out at night drinking, take cocaine, take Viagra, and has some heavy exercise, and then he passed out. So that's his with that history, you make the likely etiology carotid dissection. This is your T2 weighted image. That kind, he was really immediately brought to UCH an image. This can't be an acute stroke. But the diffusion weighted image, it looks like a huge MCA infarct and ACA infarct. Almost half the hemisphere is gone. If you look at the ADC map, you see this is the acute bit. This is where it's really restricted. This is the subacute infarct where there's pseudonormalization, and what makes this bright is the T2 effect. It's not the restricted diffusion. So this image is just highlights this message that the diffusion weighted image, or as it in proper terms called trace weighted image, is a combination of T2 and water effects. You may be familiar with the T2 shine-through effect, but are you familiar with the T2 masking effect? Now, usually my registrars, and some of them are in the audience, if they see an image like that, they would say, and the diffusion weighted image is normal. Who agrees? You have to say, I can't say, because this is just a diffusion weighted image. If you look at this, this is a typical case of small vessel disease. You have increased T2 signal here, and you have breakdown of the myelin, so you have actually increased water diffusion. So by rights, if it was just that this should be dark, and from that it should be bright, they cancel each other out. So the two effects cancel each other out, and that's T2 masking. So the take-home message is never ever look just at the DWI image alone. It always belongs together with the ADC map, and what appears normal may not be normal, and not all that appears bright equals restricted diffusion. Always look at the ADC map as well. So that's the message. Now we go through the clinical cases. Stroke. I'm really grateful to Don, who actually showed the usefulness of diffusion weighted imaging stroke already. Here again, to show the differences, this is a woman who has been suddenly become blind. Now, why did she become blind? Because she has a chronic infarct here, an acute infarct here. On the diffusion weighted image, this appears bright, the old infarct appears dark. On the ADC map, the acute is dark, and the old one is bright. So here we have two examples of two occipital infarcts, a chronic and an acute one. Now, how long does it take for the diffusion weighted image to evolve? And there's this landmark paper, which, I mean, all these papers are over a decade ago now, but here we look at the signal intensity on the ADC maps and diffusion weighted imaging. Here's the ADC maps. So within about 8 to 14 days, they pseudo-normalize, whereas the diffusion weighted image may stay above the baseline, may stay bright because of the T2 shine-through effect. And here is, from that paper, here is the example. You see diffusion weighting stays bright, bright, bright. This is day 27. And here the ADC map shows dark, 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 and then it becomes bright when it becomes chronic. So just be aware of this temporal evolution. The other landmark paper was from Boston, from the Massachusetts General. They had over 600 patients who had CT and MR, and they looked at the sensitivity of making the right diagnosis of the stroke, the right location. So CT with history was 50% accurate. That's without CT source data, that wasn't around then. CT without history was 38% accurate. MR with history at 95, MR without history 94. So you don't need a history from the MR. And my former head of department, Dr. Ivan Mosley, whom some of you might know, he called the diffusion weighted image the GP sequence. So the GP can diagnose the stroke. Okay. Now, when do we really need it? We all live in limited areas of economical limitations, and we have to be careful when we use MR. Now, I think really if you have acute infarcts in the setting of small vessel disease, and you don't see any of these cortical signal changes to indicate a cortical stroke, then you need MR. You couldn't possibly tell where the stroke is. But here in small vessel disease, in the deep white matter, diffusion weighting is really essential. What's the point of doing an MR? Well, the MR might provide you another piece of information. Of course you have here the insula, but there's another stroke in a completely unrelated territory. So you know immediately this is cardioembolic. And if you had the luxury to do some carotid imaging, the carotids are normal. So it gives you additional clues as to the etiology of the stroke. which is obviously terrible luxury. So who thinks this is a stroke? Probably none of you, because it says stroke mimic. I didn't have time to fade in the title, sorry. Anyway, the clues are there's some low density, and it doesn't quite involve the cortex. Fine, it's probably not a stroke. If you do diffusion-weighted imaging, you know immediately, aha, the diffusion is dark, the ADC is bright, therefore it must be basogenic edema and not cytotoxic edema. There must be an underlying tumor, an underlying infection, an underlying something, and this was a metastasis with an acute presentation. So the diffusion shows you immediately on the CT, cytotoxic and basogenic edema, white-light edema look dark, but on MR it's the opposite. Good. We already talked about brainstem strokes and the demarcation on the midline. That's a recent case from 2 weeks ago. Somebody's nodding up there. It's an HIV positive patient presenting with brainstem syndromes, and there was some sodium imbalance. And if you look at this, you can have acute central pontine myelinolysis with a typical trident shape. You have to be aware of. Normally you see it chronically down the line, but in the first 1 or 2 weeks, this can be actually bright. And so acute myelinolysis due to cellular swelling can restrict the diffusion. Something that Dom is very familiar is intrathecal methotrexate for leukemia treatment. You know, in children we see that often, and you see it also very often if they present with a motor deficit, and sometimes you can't even see anything on the T2. You see this, it's a cytotoxic effect, a typical methotrexate induced restriction of diffusion in bilaterally in both centra semiovali. So this is not a cardiovascular stroke. This is in multiple territories. This is a typical thing if you work in a cancer center of methotrexate induced cytotoxicity and cellular swelling, and that's partially reversible. Good. So far so good for the strokes. Now we come on to the tumors. Tumors, there are many papers, and refining the diagnosis of tumors is still a challenge. You use spectroscopy, you use perfusion imaging, and sometimes, as Jonathan already mentioned, low-grade gliomas, they have a homogeneous appearance. Well, the same applies to the diffusion weighting. So this is a well-demarcated grade 2 astrocytoma, and you recognize we have the same effect. It's T2 masked. Why is it T2 masked? Because the diffusivity in low-grade tumors, actually in most gliomas, is higher than brain, but in low-grade tumors it's much higher than brain. So it appears bright on the ADC map, and then the T2 effect, which should make that bright, and the increased diffusion, which should make that dark, cancel each other out. So therefore the diffusion weighted, the trace-weighted image looks normal. But you know, you never look at, you would never look at it on its own. You would always look at it with the ADC map. Hopefully after this talk at least. So if you have a high-grade glioma, you can already see even on the trace-weighted image, it's more heterogeneous. You know, you have areas of cystic necrosis, you have a rim of restricted diffusion, and if you grade gliomas, you always look for the areas which are the lowest. So you go for the lowest ADC, and you do measurements there, regional measurements. And if you have now the most malignant tumor, which is glioblastoma multiforme, you see that this enhancing rim with the central necrosis on diffusion, it is actually restricted. It's darker on the ADC map than the normal brain, so that's one of the rare occasions where the brain, where the gliomas are darker than normal brain tissue. That's really rare, GBMs. Except for now in experimental treatment, if you have VEGF inhibitors, that's another story, but I think that's beyond this scope. Diffusion weighting is very important because the tumors, they creep down the white matter, they reduce the ADC, and the enhancement disappears. You think they have responded, but they haven't. It's pseudo-response. But that's for another time. So there are a long string of papers who have looked at the ADC values in various tumor types, and that's the most recent one, 2012. Confirming more or less what's been said before. Low-grade tumors, they have a higher ADC. You know, a normal brain is about 7 or so. And then the higher grade tumors have a lower ADC. You note that there's also a difference whether it's an astrocytic or an oligodendrocytic tumor, and I'll come to that in a second. What makes it actually, the diffusion changes? What does it depend on in the tumors? In stroke, we know the cells swell, you have neurotoxic edema, the extracellular movement is restricted. But what is the reason for diffusion changes in tumors? A seminal paper by Sugahara from the Kumamoto group, they compared tumor cellularity with ADC maps and showed an inverse relationship. So the more cells you have, the denser it is, the more you restrict the diffusion. But it's not the whole story. There's also something about the tumor matrix. You have something which is sort of like hyaluronan or other hydrophilic substances. They are more available in low-grade tumors, and if they are hydrophilic, they facilitate protein movement, and therefore there is a positive correlation between this substance and the ADC value. So these are the two things that influence the tumors. And we published that paper already some time ago, before the more recent paper, looking at oligos and astros, both low grades in low-grade tumors. And we found, if you look at the whole brain ADC histograms, this is normal brain. The oligos are shifting more towards the normal, and the astros are higher. And with using appropriate cutoffs, you could actually differentiate histologically which was likely to be. If you have a tumor, a low-grade tumor in an eloquent location that the surgeon doesn't want to remove, there's no evidence, or the patient might not want it, so this is baseline, and you have this diffusion. I give you the diffusion values in the medial portion, so that's over twice as much as normal brain compared to that region. Now if you follow it up and it becomes more malignant, that drops, that becomes darker, and this is impending malignant change, and it goes along with the enhancement. So you should also look at diffusion rated changes if you do low-grade tumor follow-up, because it may or may not go. Diffusion tensor imaging, I'm just showing that as a fancy, not really fancy because we do it routinely now in our, or in most cases where they do glioma resections. We look at the corticospinal tract, language fibers, or here we look at the optic radiation in this temporal glioma. You have your fractional anisotropy maps, and you can map the optic radiation is displaced superiorly and posteriorly, so you know how the surgeon can work around the tracts when they want to resect it. So that's one of the applications. And of course, being in Cambridge, I have to also like to mention Jonathan's paper, together with neurosurgical colleagues, looking at the tumor tissue around the enhancing tumor, whether this is infiltrated or not. And by looking at different components of the diffusion, you can see whether there's tumor infiltration in the tissue surrounding it or not. Now, this was a bit theoretical, now we become more practical. What is really useful is the differential diagnosis of cystic masses. Meningiomas, you can venture to say, could it be typical or atypical? Typical, in speaking, typical means WHO grade 1, atypical is grade 2 and 3. And it makes actually a difference, because our current practice, grade 2 and 3, they are followed up with radiotherapy, whereas grade 1, they just followed up post-operatively routine imaging to see whether there's a recurrence, because 2 and 3 have a higher rate. And then the identification of tumors with a high nucleocytoplasm ratio, that's where you can score with your colleagues. You say, I think this is a PNET, I think this is that, lymphoma, medulloblastoma, and so forth. Moving on, this is the game. Epidermoid tumor, ADC is restricted, arachnoid cyst, it's up. Cystic metastases and necrotic primary gliomas, ADC is increased. In an abscess, it's down. Epidermoid tumor. CSF signal intensity on the T2 and on the T1 weighting. You do the diffusion weighted imaging, it can only be one thing. This is almost virtually diagnostic. That's an epidermoid tumor. It can't be an arachnoid cyst or something else. This is so typical. Also how it infiltrates front-like and so forth. It can also be useful in the post-operative follow-up. The surgeon had resected a little bit centrally. This is the arachnoid cyst to show you arachnoid cyst shows no restricted diffusion. Over everything increased, it looks like CSF. Now, if you look at an epidermoid, the surgeon had removed a little bit, but then got cold feet because it was too close to the circus of Willis and so forth. So post-operative, how much is there left? These tumors don't enhance. They may show variable signal on flare. You have this lobulated cystic thing. It's a mess on the T2. You don't know what's going on. You do the diffusion weighted imaging. You see, okay, there they removed it, and there it infiltrates still around. I mentioned, just to speed up a little bit, this would be an atypical meningioma with a lower ADC. You can already gather that it's a bit more infiltrative into the brain tissue, so that's a more malignant meningioma, and there have been early papers mapping this out. Where you really can almost dispense with any other imaging modalities in the diagnosis of abscesses, as Jonathan alluded to, when you see a cystic lesion, a ring-enhancing lesion, and you have the center. We always have to distinguish between the ring and the center. I'm talking about the center, looks bright and dark. The periphery here, there's vasogenic edema, it's the opposite. This is an abscess. This is a cystic metastasis from a CA breast. What do you expect the diffusion to be? Well, it's almost free. There's a little bit of restriction in the rim. If you look at it, that's where the malignant tissue is. But in the center, it's bright. It behaves like CSF. A word of caution, hemorrhage can also be bright on diffusion-weighted imaging. And maybe Justine is going to say something later on to that. But the characteristic here is you have a T2 star weighted, a gradient or gradient echo, and it has this hemosiderin ring. But the center can be reduced in ADC and can be bright. It's just whatever is thick, you know, thick organizing hematoma, thick pus impedes the diffusion. And the giveaway here is the rim on the diffusion weighted imaging. A nice paper by Oppenheim et al. Or Oppenheim's group showing the diffusion. That's the ADC, more or less. And this is the diffusion weighted image, signal intensity between hyperacute, acute, early subacute, and then late subacute, how an intracranial hematoma looks. Tumefactive MS, we have seen examples from Dawn. I have never seen that quite so homogeneously restricted in adults, I must say. Maybe that's a difference. But in adults, what you see sometimes in tumefactive MS, it's more the rim of inflammatory tissue, which is like, a bit like in the metastases. But then you have this open rim and maybe an appropriate history. So that can also be restricted. Coming to the tumors with the highest nucleus to cytoplasm ratio, typically lymphoma. Tumors in that location across the splenium, it's either a butterfly glioma or it's a lymphoma, but if the restriction of the diffusion is very high, then it's more likely, and very homogeneous, then it's more likely highly cellular and lymphoma. Now this is a case which I think, you know, that would throw anybody. You have somebody presenting with a scan like that and you would say, wow, no multiple infarcts, endocarditis, you know, look at the heart. Look at, you know, maybe vasculitis. Well, there's also an area here, stranger area. So, what could that be? We have enhancing areas, and this was intravascular large B-cell lymphoma. So again, lymphoma is restricted, and the reason it looks like throat is because it's intravascular. Metastases can also have different diffusion properties. And a nice paper by a Japanese group, again, sort of with a high cellular density, like small cell CA metastases, they have reduced ADC, and like sort of well-differentiated adenocarcinomas, they have a more increased diffusivity. So if you have somebody coming with multiple brain lesions and they haven't done the body CT or they don't know what's going on, then you can also say, well, I think there's this metastasis and it's heavily restricted, there are several lesions. Now, has the patient got small cell lung cancer? And then said, yes, indeed, that's what the patient has. Or a patient with a known adenocarcinoma, well differentiated. Well, here, that's the enhancing bit, and that's the diffusion-weighted image. It's not restricted. So it may help differentiating metastases. And that's the ADC mapping that one. Ewing sarcoma. Ewing's is very dense. It can infiltrate the bone. And you actually, if you look for bone metastases on the skull, you know, if they have a Ewing's patient and say, is there any cranial metastasis? Don't waste your time, just look at the diffusion rate imaging. I saw stuff in the clivus and things. It's so heavily restricting. I mean, here it pushes into the brain. It's a classic one. It restricts the diffusion and it's very bright on the diffusion weighted imaging. And you must also know, the other good thing about the diffusion weighted imaging, it's a fat saturated image. No. If you want to know whether something is fat or not, diffusion weighted imaging, that's a fat saturated image, so you know you have no diploid fat. Good. Next big topic is infection. We had already a little bit talked about abscesses. I'm going to speed up. Again, typical abscess, dark cavity, surrounding ring, inner lesion. Nice paper from India, who actually looked at the viable cell count, of bacteria or infective agents in the cavity and correlated it with the mean ADC using different b-values, and they found that with a higher b-value there was a very good correlation between the viable cell density and the ADC restriction, but also very good correlations at more clinically used ADCs. How can we use this? This is a case from our own practice, pre and post TB treatment. You see the abscess here. After treatment, there's still some enhancement, but the cavity gets less, the restricted diffusion goes down. TB may be variable, but in that case, it's actually restricted. Pneumococcal, meningitis, T2 looks normal, the T1 looks actually normal. And then you have this in the dependent ventricles. So very useful. Herpes encephalitis. Now, herpes encephalitis can give you a cortical high signal in the acute stage, like here. So the other thing you have to look at when you see something like that, the differential diagnosis is CJD. The presentation is different. Patients with CJD, sporadic CJD, they will have a rapidly declining dementia. Now, my big favorite topic, HIV encephalopathy. You may not see it in Cambridge, but we see a lot in London. What happens here, it's complex how the virus interacts. It doesn't damage the neurons, it damages the glia, and there's some combination of demyelination and processes going on. You see often this hazy signal around the T2, and again, it's increased on the diffusion weighting. So that's the diffuse pattern, again, your favorite T2 masking. And you can also get the more focal pattern. You have these areas, focal pattern in the white matter, they're not infarcts. This is the ABC map, it's increased, and this is the only fractional anisotropy map I'm showing you. The fractional anisotropy means where the tracts are bright, it's highly organized. Now you can see that there is a lesion here, which you don't detect on the other images, but it's already infiltrating the white matter there. And we used some quantification. I have an MSc student looking at the CD4 count versus the whole brain ADC, and there's a nice correlation. So the lower your CD4 count was ever, the better it correlates with the ADC, with the myelin damage witnessed by ADC. Patients with AIDS, they often get a PML, and this is progressive multifocal leukoencephalopathy. It becomes more and more relevant because this has also been seen in patients with hematological disorders who are immunocompromised. But and I urge you to pay attention to that because it's more relevant as we have immunosuppressive therapies like for multiple sclerosis and other things in Crohn's disease or rheumatoid arthritis. If you're severely immunosuppressed, you may get this progressive multifocal leukoencephalopathy, which is caused by the JC virus. And the characteristic finding is if you have a T2 lesion infiltrating, it would be dark on T1, but it's this edge, it's like a flame-like edge on a bead around the outside. And a colleague of mine compared that as like an Australian bushfire. You have the burnt earth here, and this is where the inflammation takes place for the JC virus. We did some studies with higher B values, and again you highlight this edge on the B3000 much better. So it's really very, very useful to detect PML. If you see that on the diffusion weighted image, it's very typical. Have you got 2 minutes for neurodegeneration? Yes? Okay. Now, you have a patient, and again, we will hear more this afternoon about dementia imaging, but one of the rapidly declining dementias is caused by sporadic CD, CJD, and hopefully now first a case of variant CJD. The mad cow disease, or la vache folle, as the French say, claiming that there are then in France. you get the hockey stick sign, thalamic involvement, basic ganglia involvement, it's very bright in diffusion weighted imaging. And the corresponding ADC map. So I think the restriction here is due to the spongiform change. So it's the spongiform change which restricts the extracellular space and increases the diffusion. Now in the sporadic CJD, which will be much more common, hopefully, because the mad cow disease is sort of slightly disappearing from the scene, you look at less of thalamic involvement. It depends also on the genotype and so forth. It's too far to go into that. But the important thing is the cortical high signal. On the flare, you just as a soupçon that this is a high signal, or in the Parkinsonian variants, you have in the middle cerebral peduncles, that signal differentiates between progressive supranuclear palsy and multisystem atrophy. So, finish with a nice colorful image. Here we have the tracking. This is Parkinson's disease, looks close to normal, bit of fiber loss. Here we have progressive supranuclear palsy. You lose a lot of the cortical fibers, and that's at an early stage, and then in advanced multisystem atrophy, you lose your middle cerebral peduncles, they are gone, or at least the anisotropy in them is gone. So to summarize, I hope I could convince you that DWI is firmly established in the clinical practice for stroke, cerebral mass lesions, and infections. That you always have to look at both the ADC and the DWI, and that sometimes now the questions are higher p-value imaging for certain conditions, ADC measurements in clinical practice as a move to more quantitative radiology. Well, I leave that open, but I just wanted to sort of plant that seed in your minds, and thank you very much for your attention.